I'd like to call this hearing of the House Military Construction and Veterans Affairs Appropriations Subcommittee to order. Welcome, everyone. Welcome, Mr. Secretary. Today, we welcome the Department of Veterans Affairs Secretary Wilkie and Dr. Stone, the executive in charge, Secretary Robert Wilkie, and Dr. Richard Stone, the executive in charge for VHA. We appreciate you both being here and look forward to exploring topics outside of our traditional budget hearing. Given that we had a slight delay in the budgetary process, we thought this was a perfect opportunity to be able to bring you in when normally we don't have that opportunity in terms of the time frame that we're dealing with, to explore the myriad of issues that our veterans are facing. Mr. Secretary, you're currently leading an agency that is facing some fairly significant changes that will fundamentally affect how veterans will receive care on a daily basis for years to come. First, I think we need to address the cost of care. With the passage of the Mission Act, the VA will need a sustainable funding stream that continues to support core VA programs. And I absolutely do not want to see community care funded at the expense of traditional VA medical services. Second, we must make sure that the community care overhaul is done correctly. Although the Mission Act called for a restructuring of the department's outside medical care, and even though I have heard you say in your confirmation hearing that you will, quote, oppose efforts to privatize the VA, I am very concerned that recent access standards announced by VA will ultimately send more veterans into the community. The subcommittee staff has shown me this flow chart. This flow chart, which you can see not very well on the screens, was provided by the VA regarding community care eligibility, has every pathway of care leading the veteran to be shifted to the community. And I would really ask the committee members to read through this entire, even though it is complicated, this entire flow chart, because there is no path, Mr. Chairman, in this flow chart that leads to care at the VA, except in perhaps the rarest of circumstances, and that is deeply concerning. If there's not an intentional effort to privatize the VA, this sure seems like a backdoor effort to back ourselves into it so that that's the result. Third, we have to make sure that the medical records modernization that we are going through is done correctly and managed correctly. As you know, this complex project at the moment is projected to cost $16 billion. Now, to put that number in perspective, because when we deal in billions and trillions of dollars, it can be dizzying. The nuclear-powered aircraft carrier, the USS Gerald R. Ford, the lead vessel of the U.S. Navy's latest class of carriers, cost $13 billion. That should give us some idea of just how massive this project is and how expensive it is. Mr. Secretary, implementing and improving the VA's electronic healthcare record system and executing Congress's mandate for full interoperability with DoD's systems has been this committee's top priority for several years. Mr. Secretary, fourth, I'm curious as to why 17% of VA's leadership positions are still vacant 2 years into this administration. You are in the middle of two massive overhauls, and both positions, the Deputy Secretary and the Undersecretary of Health, who are supposed to oversee the EHR modernization and the Mission Act implementation, are currently vacant. Congress is already struggling to get detailed briefings, real transparency, and a true partnership on implementing these initiatives, and those key vacancies make it even harder. And finally, I'm extremely concerned about the VA's efforts on mental health. I was horrified, and I'm sure everyone in this room was as well, to read in the Washington Post an article titled "The Parking Lot Suicides," which detailed 19 suicides that occurred on VA campuses from October 2017 to November 2018, seven of them in parking lots, according to your department. Mr. Secretary, the most recent parking lot suicide was in my home state of Florida. The Trump administration has said over the past 2 years that preventing suicide is a top priority. It has certainly been a top priority of this subcommittee. And you also mentioned in your State of the VA address that veteran suicide is one of your top priorities, and I take you at your word. But I have to ask the question, what is going on? We have increased funding for mental health every year, and I can state for a fact that every member on this dais, every member on the Appropriations Committee, and every member in this Congress strongly supports VA mental health programs. So if there is one thing, Mr. Secretary, that we need to get right, and we've spoken about this privately, and I know you agree, it is preventing veterans' suicide. It is an epidemic. We have to ensure that you have adequate resources to do so, but once we give you those adequate resources, you have to succeed. And success, what success looks like to me, is significantly reducing veterans' suicide. So I appreciate you both being here today. I look forward to your testimony, Mr. Secretary, and now I'd like to recognize my ranking member, Judge Carter, for his opening remarks.
Thank you, Madam Chairman. Well, good morning. I want to thank our chairwoman for holding this hearing. Excuse me. I also want to thank you, Secretary Wilkie and Dr. Stone for being here. I look forward to our discussion on how we're doing in serving veterans who have kept our country safe and free. I was pleased to read in your written statement that customer service and trust scores are rising and that the VA is leading in other ways, such as safe and appropriate use of opioid medications. But there continues to be problems and challenges. Just yesterday, the Washington Post reported on how the VA Medical Center in the nation's capital is ranked in the bottom 10% of all of the department's hospitals. News articles like this are disturbing, not only for the problems they reveal, but also because they obscure the amazing work and dedication of so many VA's employees and volunteers. I think you would agree with me that there is no excuse not to do the best for our veterans. Speaking of dedicated employees, I'd like to mention Christopher Sandals. He just left us, and we're really going to miss him. He has been the director of the Central Texas Veterans Healthcare System in Temple, where he worked tirelessly to revitalize VA services. He's a devoted public servant and has been a trusted friend to both my office and the community at large. I'm sad to lose him to the VA's San Antonio office, but I know he will continue to be an excellent leader who puts veterans first. In closing, Secretary Wilkie, I'd like to publicly invite you to visit Central Texas to see our facilities and incredible staff, as well as the veterans they serve. Our congressional district has the most veterans of any district in Texas. We would give you a big, hearty Texas welcome, and you've already been there before. You just told me that. Learned a little Texas history, and you might even get some good Texas barbecue. Thank you for, I hope you'll consider this invitation, and let's make it happen soon. I yield back to my time.
Thank you, Judge Carter. And Secretary Wilkie, your full statement will be entered into the record. And if you can summarize your remarks in 5 minutes. Thank you.
Thank you, Madam Chair and Judge Carter. I will start, Madam Chair, with the conversation that you and I had. I am relatively new to this side of the House. I've spent most of my career in the other body. And my first full day on the job at VA was August 1st. And by way of my own history, I am the son of a gravely wounded combat soldier. I have served as an officer in 2 services, the Navy and the Air Force, and I've been a senior leader in the Pentagon. So when the President asked me to take on this wonderful opportunity, it was my father's recovery that was on my mind. And as a result of that, I am very proud to be part of the VA team. Last September, I testified in front of the Senate, and then later in December to a joint House-Senate authorizing committee that the state of the Department of Veterans Affairs is better. It is better because of the support from this subcommittee and the authorizers. It is better because of the attention paid to the department by the President. I said then that we were on the cusp of the greatest transformative period in VA's history. I now say we are in the middle of that. But in addition to the things that you, Madam Chair, pointed out, let me talk for a minute about where VA is as a department. Last fall, the Partnership for Public Service, for the first time in decades, listed the department as one of the best places in the federal government to work. In addition, the Annals of Internal Medicine, put together by Dartmouth, said that the medical care provided our veterans at our VA facilities is as good or better than in any region of the country throughout the private sector. And the Journal of the American Medical Association said that our wait times in 3 of the 4 major categories exceed any found in the private sector. We are in the middle of several major modernization efforts. But the first thing I will say today in terms of a new initiative is that I will be announcing that for those who hold the Purple Heart, the recognition of wounds taken in battle, that we will now place those who hold that decoration at the front of the line when it comes to claims before the Veterans Department. Appeals modernization, which stems from that. We are on schedule to fulfill the mandate of the Appeals Modernization Act, and we announced last week that the Appeals Modernization Act is now being completely fulfilled. As you mentioned, we are adopting the electronic health record used by the Department of Defense. I say that as part of personal pride. I mentioned my father earlier in my statement. When he finished 30 years of service, he concluded that service after jumping out of airplanes for most of that time and receiving terrible wounds in Vietnam, holding an 800-page paper record. It was my decision, and in cooperation with then Secretary of Defense Mattis, that the days of our veterans carrying around one non-interoperable record will no longer be the case. That will be the center of the transformative period that we have now entered, a transformative period that includes the modernization of our VA supply chain and the reform of our human resources capability. We are on the path set by this Congress to fulfill the mandate given to us by you in the Mission Act. And I will conclude by saying what I did in front of several VSO conventions about what our mission is. I believe that our mission is to help remind all Americans that they sleep soundly at night because of the service of 19.9 million American veterans, 9.5 million of whom are in our VA system. So I look forward to answering your questions, and I thank you for your many courtesies to me.
Thank you, Mr. Secretary, for your remarks. Members will proceed with the standard 5-minute rounds, alternating sides, recognizing members in order of seniority as they were seated at the beginning of the hearing at Gavel Inn. I would ask just that members be mindful of the length of time it takes you to ask your question, leaving enough time for the Secretary or Mr. Stone to answer within your 5-minute time block. With that, Mr. Secretary, as I mentioned in my opening remarks, you recently came out with the proposed Mission Access Standards that allow greater flexibility for veterans to receive care in the community. And that's certainly what the Mission Act's intention was. However, the flow chart here is concerning because, as I mentioned in my opening remarks, every single pathway here essentially leads a veteran to care in the community as opposed to care at the VA. This, to me, looks like the VA is trying to push veterans out into the community. So please tell me how this process that you've laid out here in this flowchart is not taking giant steps towards privatizing the VA.
Thank you, Madam Chair. Let me go back to the history of our department. My most famous predecessor was Omar Bradley, who took the reins of this department after the end of World War II. Since that time, about 30 to 35% of all VA care has been in the private sector. What that chart shows you is not a deliberate path to privatization. No one has advocated for that. This Congress certainly didn't intend that, and I do not intend that. What that does mean is the mandate of Section 104 of the Mission Act, which says that the interest of the veteran will be central to any decision that we make. What that does is, if we are unable to provide a certain service to that veteran then has the choice to go into the private sector to receive that particular type of care. It doesn't mandate that we are turning veterans out into the street. And I believe that based on the statistics that I gave at the beginning of my presentation, that we have a customer service satisfaction in VHA of about 89.9%. Veterans will go where people understand their culture and speak the language of service. What we saw with the Choice Act was less than 1% of those eligible for choice took advantage of that.
Mr. Secretary, I want to be mindful of my own request on 5 minutes. So I've heard you say many times, you've said it to me privately, and I've heard you say it publicly, that you're not interested in privatizing the VA, and that's not your intent. So how are you working to keep veterans in the VA system? Because this chart certainly is not demonstrative of that goal. Are you making any efforts to encourage veterans to continue to receive care within the traditional VA system if it's the best option for them? And most importantly, under the current Choice Act, the access standards, 8% of enrollees are eligible for community care options. And the new proposed Mission Act standards will increase the eligible enrollees that can receive care outside of the VA to 20% for primary care, 31% for specialty care. That will more than double the number of veterans eligible for care in the community, and that'll undoubtedly increase the cost of the program, and we'll still be supporting medical services, as we should, in the VA. There has not been a real excellent ability demonstrated by the VA at projecting the actual costs of the Community Care and Choice Act costs. So how are you not going to have an explosion of costs here, and how are we not going to be driving veterans out of the VA system?
Well, what you described is my point, eligible. And what we are doing in VA today is making sure that we change to fit the new demographics of the veterans population in the country. We are expanding the aperture on women's choice. We're expanding the aperture on traumatic brain injury and a host of other issues that particularly affect the modern veteran, but eligible for the veteran to make the choice. I am a classic example of what happens with choice. As a youngster, my parents under Champus, the precursor of TRICARE, when Fort Bragg could not provide me with medical care, Fort Bragg sent me to Duke University. The rest of my care that was not addressed by Duke in that particular circumstance was taken care of by military medical facilities. So again, the mandate is to keep the veteran's health at the central node of our change, but allow the veteran to choose, if we don't have the service to keep him healthy, the opportunity to go into the private sector. And as we've seen with choice, and as we've seen throughout our history, the vast majority of veterans choose to stay in our system.
Thank you very much, Mr. Secretary. Ranking Member Carter.
Thank you. I think you know that I was proud to sponsor the provisions in the Mission Act that allow the VA to cover medical costs for someone who donates an organ or bone marrow to a veteran, even if that person is not eligible for VA services. Last week, VA announced that this new authority will be addressed later and in a separate regulation from the proposed access standards. Please explain the rationale for this decision. Are there unique challenges to implementing the new authority? What is your projected timeline to issue a regulation on this?
Ranking Member Carter, we did separate that out. The complexity of the access standards became such that we felt that it was much more straightforward for us to bring these out as separate pieces. That is actively in development, and within the next 3 weeks, we will be releasing this additional regulation. Now, we are very proud of our transplant program and the fact that it leads the way in quality in many districts and in many areas of the country. And therefore, it's essential that we bring this out and link it back to the access standards.
My concern for doing this in the first place was I keep hearing, and it seems to be a fact, that about 1% of American population actually serves in the military. And if you couldn't donate unless you were a veteran, that leaves you with about 99% of the people not eligible to donate. And that seemed to be a ridiculous rule.
And we appreciate, sir, the leadership in this. We do participate in the National Donor Program lists, and therefore our veterans are eligible to receive donors from across the country. And previous legislation that you are well familiar with has led us down that road.
Well, I'm looking forward to, that once you're in the category of you either get a donation or you die, delay is very concerning, and that's what I'm trying to avoid. So I'm looking forward to the new regulation. I'll be looking for it.
Yes, sir.
New construction and facility maintenance. Somewhat like this subcommittee, you're required to take a broad look at the conditions in current facilities and those needs. I know you're under the Mission Act. VA also is conducting capital asset reviews. Tell us about how you approach construction and maintenance programs. What factors do you consider when thinking of building a new VA medical center, and how much of a role does community support play in that decision?
Judge Carter, we are at the beginning of the process of conducting major market assessments across the country, which will then inform the Asset Infrastructure Review Commission, which was established by the Mission Act. The current budget for construction for this current fiscal year is about $13 billion. Our purpose in the market assessment reviews is to determine where assets need to be delivered to address the greatest need of our veterans. We had the contract kick off for the market assessments in mid-December, and phase one of that will be completed in 2019. In your district, as you mentioned, the fastest growing VA district in the second fastest growing state when it comes to VA population. We are moving on the road network in Temple, and we are prioritizing Temple's VA center to address the needs of that exploding population. So this is part of our reform, and it's a vital part of our reform. I would like just to digress for a minute. I didn't finish answering the question about privatization and where our veterans vote with their feet. Last year, there were 58 million appointments in the VA. That was an increase of 630,000 from the previous year. So our veterans are voting with their feet, and they are voting to stay in our system.
My time has expired. Thank you.
Okay, Mr. Case.
Mr. Secretary, I spent in the district work period, I went to a Veterans Fair in Honolulu. You say here that you have been to Hawaii. Thank you for that, first of all. And I was struck by some disparities in that fair. I went relatively unannounced. They knew I was coming, but I had no official role other than simply to walk around and talk to people. It was a fair where you had our federal effort represented very well as state, as well as private. And so in that sense, it was a very good example, I thought, of cooperation across the various sectors in caring for our veterans. And there was a great diversity of veterans there as well, some very senior veterans as well as some very recent veterans. And I guess my overall impression was that there were so many programs that were of benefit for the veterans, but but being delivered somewhat inconsistently. And I reflected that perhaps Hawaii, and I don't want to focus only on Hawaii because we have many, many veterans across the country, that there was a great disparity in availability of care, quality care, because in some parts of our country there is great care, very available, very timely, and then in other parts, and this is true inside of Hawaii itself, it's very hard to get the care, you wait a long time for care, and it's not exactly the right care that you need. And so I would like you to just step back for a second and give me 3 of the biggest challenges you think you're facing right now and what you really want to try to cover the continuum, to kind of take all of these great programs and make them all work better together for a greater variety of veterans across this country.
Well, I will focus on Hawaii. One of the reasons I went to Hawaii is that it's one place in the country where you don't have to explain military service to anyone. In its unique history, I believe I was the first VA secretary to visit the Big Island and had discussions with Governor
Since that's my home island, that's a very good answer. But,
yes, sir. But let me tell you why I focused on Hawaii. 129,000 veterans in Hawaii, and about 55,000 are not part of VA. What I talked to the governor about was working with us to reach those 55. The reason it is so uneven, and there were probably many people at that seminar with you who are not part of the VA system. And this impacts on issues like homelessness and suicide. Those are the 3 areas, I believe, that we have to form a more robust partnership with the states, with NGOs, with VSOs, getting people into the system. Suicide prevention, as the chair stated, and homelessness. Hawaii has a homeless problem. And with so many of those veterans outside of our system, I need to put more resources into our homelessness outreach because there is a continuum in Hawaii that I saw. Homelessness, suicide, mental health, they all form the basis for a great problem. If we can make it work in Hawaii by putting more resources in, I think we can make it work in other parts of the country. The other side of that, and I know you're concerned about it, and it is something that's been central in my 7 months, is the outreach to Native peoples. Your sister state in Alaska, over half of the veterans aren't in our system. Hawaii and Alaska are 2 states where people go to get lost, and we have to find them. And I've asked the Native peoples to help in Alaska double the number of tribal representatives out in the islands of the Pacific, where you have the highest per capita service and the highest per capita awarding of the Medal of Honor amongst the warrior cultures of the Pacific. We haven't paid enough attention to them. And so those are the areas that I would focus on. And I'm not saying that because you're asking the question. I think it was evident by my approach in Hawaii, and I'm headed out to the Pacific Islands later this year.
Thank you. I would really encourage you on the outreach because care is accessible to many, but it is inaccessible to too many. And as you well saw, especially on the island of Hawaii, the Big Island, I think you said it well. Sometimes people go to some places to get lost. So it's not a matter of just being available. It's a matter of actually going out and reaching veterans who have those needs where, frankly, many times they don't want to be found. Thank you very much for your comments. Very relevant.
Thank you, Mr. Case. Mr. Rutherford?
Thank you, Madam Chair. Mr. Secretary, I really appreciate you being here this morning. And in fact, I also have some constituents here this morning from Florida who do some amazing work with canines, working with veterans who are suffering from PTDS and also TBI and MST. As you know, we're waiting for the report on the service dog study to be completed and released. Can you give me any timeline on that?
Yeah, I can't, but we'll get it for the record. And but that program has been very positive, and we've experienced what we think are really outstanding outcomes from the use of canines in both traumatic brain injury, chronic traumatic encephalopathy, as well as PTSD.
I would say, sir, that in my previous life as the Undersecretary of Defense for Personnel and Readiness, I did expand the use of service dogs for our wounded veterans. I know the impact that has had on veterans who have suffered from the conflicts in Iraq and Afghanistan. So I'll get you the date on that.
Thank you. I will tell you, Canines for Warriors down in St. Augustine has had an amazing, I mean, the anecdotal stories are amazing of the lives that they are saving with that program. So I wait anxiously for that report.
If I might add, and this goes back to Madam Chairwoman, your comments in the opening, transitions in life, and especially transition from uniformed services, results in risk. And that risk is about isolation. What the canines do is correct that isolation. And all of us grew up in a time where there was cohesive communities. Many of our service members do not come from cohesive communities, and therefore we appreciate what you're saying, we agree with your impression, and we will get you the data as soon as we release it.
Thank you, Dr. Stone. Also, Mr. Secretary, due to our high veteran population and lack of a VA medical center other than a couple CBOCs that we have, providing prompt payment to our community providers through the CHOICE Act is critical to our success. I can tell you in Northeast Florida, we've had some serious issues with payment, and as a result, we've actually had facilities write letters that they are no longer going to treat veterans because their accounts receivable have gotten to be so enormous. And I know the Mission Act was designed to address some of that. Can you tell me how that's going forward?
Yes, sir, and you have hit on something that was stunning to me. The best example is actually what happened in Minnesota with the Mayo Clinic, a clinic that really began as the outgrowth of medical need after World War I. Mayo doesn't participate in community care any longer. What we have done is we have let the contracts for companies to take over the accounts for community care. Choice cannot exist, as you pointed out, particularly in the fastest growing veterans population in the country, which is Florida, unless we pay our small town doctors, our community hospitals and clinics. So we are on track with the Mission Act to have the 4 regions of the country and the Pacific Islands, which would be Region 5, to have those account procedures in place. Legacy payments will be taken care of first. Place like Florida, Texas, and Hawaii will probably be at the top of the list because of the size of the veterans population.
Thank you. And last question before my time runs out here. The Veterans Healing Veterans Program under Section 304 and actually Sections 301 and 303, which deal with, the getting doctors in and keeping them into the VA, good qualified doctors. Can you talk about those programs and how they're moving forward now after the Mission Act?
Yes, hiring veterans that have recovered from addiction as part of Veterans Healing Veterans has been a very slow process. And although we're making progress, really getting the right veteran that it ensures that they are well qualified to take on that role has been slow. I think the easier portion of the question to answer is really about retaining physicians and providers. We have done very well at both recruiting and retaining physicians, recognizing the fact that there are remote areas of the country that are difficult to reach. And in those remote areas, this is why we've dramatically expanded our telehealth services.
Thank you. My time has expired. I yield back.
Thank you, Mr. Rutherford. Ms. Bustos?
Thanks. I want to thank the chairwoman for hosting this committee hearing and also our ranking member. And thanks to both of you for your willingness to be here in front of us. Mr. Secretary, I love how you mentioned the Big Island and your focus on that. I'm going to take you to Rock Island, okay, along the Mississippi River. So that's the county where I live. And just to give you a little context about the congressional district that I serve, it's 14 counties, 7,000 square miles, goes up to the Wisconsin state line. Of course, the western border of the district is the Mississippi River, and we border Iowa. Of the 14 counties in my congressional district, 11 are almost entirely rural. And we have some unique needs in rural America. So this doesn't just apply to a district like mine, but in rural areas across our country. And what I hear when I visit any one of the 7 VA clinics that serve our congressional district is, first of all, I think most are very satisfied. I hear a lot of good reports from our veterans, very satisfied with their service. But transportation is an issue in a lot of our areas. How they get to 2 of the hospitals, VA hospitals that serve the congressional district that I represent, are outside the state. One is in Iowa City, one is in Madison, Wisconsin. The other one is, an hour away from a good part of the people who go there. So I'm just wondering if there's any way to address transportation needs in rural America. That would be like 1A, and then 1B would be any thoughts of partnering, for example, with mass transit districts, or just kind of what we could see ahead where I could give answers to these veterans who bring this up.
Well, in my original presentations, I talked about the leadership of VA and the nation not understanding the scale of the American West, but I would add that Illinois is the plain state and is just as every bit rural as Montana and Dakota. The reforms that we need to implement to make VA a modern 21st century healthcare administration include making access, as you pointed to, rural America a reality. One of the ways we're doing that is expanding telehealth. That also addresses the mental health issue that the chair has championed for so many years. Getting our veterans on the screen with doctors across the country, in their homes, which is vital in the doctors tell me for mental health, that is the key, and also addressing the transportation needs. But I think immediately getting them access to our VA medical centers through telehealth, and also coming to this committee and to your counterpart in the Senate and discussing ways that we can make it easier for medical health professionals to come to VA and spend their time in rural areas of our country. That, to me, is as great a concern as any, and I'll let Dr. Stone finish the answer.
So many of the VSOs support us in rural areas with the donation of vans and then run various transportation districts, and that's been a great partnership. And we'd be happy to discuss that in your area to see could we get it expanded into that. In addition, going back to the chairwoman's opening concept of holding up the sort of flow, in the Mission Act, there are 6 ways in which veterans qualify to go out. One of those, written into statute, is it in the best interest of the veteran? And in some of these areas, they are so remote that it is in the best interest of the veteran to not travel a great distance, even when transportation is provided. And that's one of the things that we really like about those sort of 6 criteria in the Mission Act, is that we can reach into that to do what's best for veterans.
And I would add, with Judge Carter sitting here, I've said in many of my speeches that the loneliest sign in America is on Interstate 10 in Houston, and it says El Paso 910 miles. Those distances are something that we have to overcome with modern technology. And I believe that Mission gives us the framework to do that.
Thank you. And Dr. Stone, I'll follow up with you separately on, we do have some clinics where the transportation literally is, we don't have a partnership with the VSOs who are providing that transportation in some of our clinics. So we'll follow up with you on that. And again, really appreciate both of your service to our country.
Thank you, Ms. Bustos.
Yield back. Thank you.
Thank you. Ms. Roby?
Well, good morning, Mr. Secretary, Dr. Stone. I'm not really sure where to begin other than to say I'm grateful for the opportunity to have you here today. I'm grateful to be back on this subcommittee for this Congress. Central Alabama VA has continued to be one of the worst VAs in the country. We had Dr. Teresa Boyd here, your Undersecretary for Clinical Health, 2 weeks ago. I'm not sure if you've had a chance to talk to her about our discussion, but specifically VISN 7 and Central Alabama's Veteran Healthcare System, CAVIX is what we call it, which falls within the jurisdiction and the facility's current state. I'm not sure, Madam Chair, that my 5 minutes is enough for you to fully appreciate and us to have a real conversation about what's been going on there for many years. But in my time in Congress, I have worked diligently with leadership there and at the VISN to make sure that our veterans are receiving the best care that we can give them. And as I said to Dr. Boyd, we don't know each other well, but you will learn in the course of this time that I'm very passionate about this issue, but I'm very frustrated. I don't understand why the VA works on a bell curve, and somebody always has to be at the bottom of the barrel with a 1-star. We should want every single healthcare system across this nation to be the very best that it can be in serving our veterans. But we're unable to get simple things right, like just saying hello and greeting a veteran in the morning when they come in for their appointment to make them feel valued and that somebody cares, to very egregious behavior that I can give you some really specific examples, which I would like the opportunity to do so that you can fully appreciate what's been going on in this healthcare system over the course of many years. A culture of complacency, gross mismanagement that has taken place over many, many years. Again, I would like the opportunity to talk to you very specifically about some of the worst cases that have come through. But I can tell you, I want to be in the grocery store and have a veteran come up to me and tell me how wonderful their experience was at the VA, not have to look into a man or a woman's eyes that has served our country honorably and see tears in their eyes where they have just flat out given up because they cannot get appropriate care. We should be giving them the best care in a timely fashion, and it just isn't working. And so I'm grateful again for the opportunity to be here with you today, but I'm tired of getting status quo answer as to why we continue to be one of the worst in the nation. And so, again, I'm hopeful that we, over the course of the next weeks and months, can cultivate a relationship so that you can fully appreciate and understand what's going on. I would like to invite you to come to Alabama to visit the VA there and spend time seeing firsthand what's going on. But this is not working. It's not the way it should be, and it is a huge disservice to our men and women who have served our country.
Well, let me say I'm in Alabama a lot. My parents are in North Alabama, so that's an easy thing for me.
Well, good. Come south,
they're in Hampton Cove. So let me tell you, I have said, and you hit on it, that the prime directive for me is customer service. It is vital that the first experience a veteran has is that greeting. And I've said that it is not the veteran's job to employ a team of lawyers to get the VA to say yes. It's up to us to say yes. And I am particularly cognizant of what has happened in Central Alabama. I know that in many places in the country I've started, because of the legislation passed by this Congress, I've started to replace leaders and hold them accountable. And in terms of the specifics as to what has been done in Central Alabama, Dr. Stone can fill in the most recent history, but I take what you say seriously.
So I have talked to Dr. Boyd about the conversations that you've had, and we welcome the partnership to work with you. Central Alabama demonstrates the problem with the sales system and the bell curve, because there's parts of the functioning of Central Alabama healthcare system that are actually doing very, very well. For instance, mortality during hospitalization is some of the lowest in our system. Secondly, RN turnover is very, very low, and we retain some excellent medical specialists and excellent RNs at very high rates. That said, the simplicity of courtesy to our veterans is at the lowest across our entire system. So this may reflect problems in our leadership, but yet our leadership team is fairly stable, including almost 2 years in place of the current medical center director, and a willingness of that leadership team to work with our corrective action team, what we call our RAPID team, which clearly has not worked rapidly in Central Alabama. But this is a deeply troubled facility, and one that, although there is some positive pieces of their performance, the concept of customer service, which is the Secretary's prime directive to correct customer service, has not impregnated that facility effectively at all. So
my time is way expired. But Madam Chair, thank you for. Just please, can we have a continued discussion outside of 5 minutes? I really would like to work with both of you on this. We're just not getting it right, and we've got to get it right.
Thank you. And Ms. Roby, thank you for your compassion and your leadership. There's just no excuse for there to be not just a weak link, but a totally broken link in any portion of our system of care for our veterans. And, you know, it would be one thing if this was a recent deterioration that, you know, we just learned about and need to begin to try to get right. But this is a grossly irresponsible, ongoing problem that has not been corrected. And it is not just the priority of Ms. Roby, but it's the priority of this committee, and we're here to back her up, just so you understand. Thank you. Mr. Bishop.
Thank you very much. Let me take this opportunity to welcome Secretary Wilkie and Dr. Stone. And let me start by echoing Ms. Roby's concerns. I represent a part of the Central Alabama Vision, which is East Alabama and West Georgia. I hear the very same concerns from my veterans who go to the Central Alabama facilities. And I'm equally disappointed, not because, Mr. Secretary, you have not personally been responsive, and not because I don't believe that you and your staff are sincerely concerned, but we still have those persistent problems. They're systemic, and they very much need to be addressed. Let me thank you for your efforts in the startup of the new VA clinic, community-based clinic in Columbus, which will go a long way to satisfying the concerns that some of our veterans in West Georgia have with regard to the service that they're getting at the Central Alabama Vision. But you need to know that there are some very systemic problems there. I have heard continuously, particularly a drumbeat from my constituents of ongoing problems that exist with regard to travel reimbursement. Can you discuss why the veterans continue to face this issue with such a lag between the time that the travel reimbursements are issued and the time they actually incur the expenses? Because it creates a real burden for them, particularly those who have to travel and don't have personal transportation, to get back and forth for their veterans treatment.
Yes, sir. We have initiated in the 7 months that I've been privileged to be here a focus on our entire benefits compensation program. People think of Georgia and they think of Atlanta. Georgia is primarily a rural state. You represent Fort Benning, but you're surrounded by farms.
Right, half of my district is rural and half of it is urban.
Yes, sir.
Macon, Columbus, and Albany are the urban centers, but everything in between is rural.
So we are,
50-50.
yes, sir. We are looking at making sure that not only are people reimbursed, but they are reimbursed to reflect modern conditions. Many of those reimbursement rates are based on an old formula. So we are taking a look not only to get those payments out, but to modernize them. I mentioned previously that I have a particular concern for rural America. And one of the things that we're doing to alleviate some of the burden on those families is the expansion of two things, telehealth and then the mandate of the Congress to compensate those family caregivers who take care of Vietnam veterans. In particular, the majority of your veterans population in Western Georgia or Vietnam, and getting that care closer to home and supporting those families is vital as well.
Okay, thank you for that, and we'll continue to monitor that. I understand that some of the VA's local contracting officers have overturned or denied contract awards based on a misinterpretation of the Supreme Court's decision in the Kingdomware case, and that VA's related guidance regarding set-aside rules. By overturning the prior contract awards and declining to exercise contract option years under properly competed contracts, they're potentially increasing costs for the VA, and they're limiting veterans' access to quality care. What are the VA's specific plans to address the Government Accounting Office's recommendations regarding inconsistent decision-making in the contracting process, and what is the time frame for action? And what actions will the VA take to ensure that the issuance and consistent application of new guidelines are to implement the Government Accounting Office's recommendations?
So I've met with the leadership of GAO, and my instructions to the department are that we do everything in our power to fulfill the recommendations of GAO across the spectrum, not just here, but in other areas. As the chair pointed out in her remarks about suicide, there's a recent GAO report on that. So the Kingdomware issue is one that we are working with GAO on.
You have a time frame?
I don't have a time frame, no, sir. But in the last 7 months, it has been something that's been on my plate.
Can you get back with us?
Oh, I will, yes, sir.
With a timeline?
Absolutely.
Thank you very much. My time has expired.
Thank you, Mr. Bishop. Mr. Hurd?
Thank you, Chairwoman. Gentlemen, appreciate y'all being here. First, let me start off with, Mr. Secretary, you have a phenomenal representative in West Texas. The West Texas VA Director, Cloudy Jangdari, is awesome. We just opened up a facility in Fort Stockton where about 4,000 veterans are not going to have to drive 4 hours just to do simple things like get blood drawn. Also, you talked about telehealth. I have more cows than people in the middle part of my district, and you can't have telehealth if you don't have telecommunications, and we're going to put a couple of people in headlocks to make sure that the right kind of telecommunications are getting into some of these facilities. Some places they're a block away. And I'm on the case. We're going to crack some heads and hopefully get back to you with a good report. Let's talk electronic health records. And since I've been in Congress 4.5 years, I know there's been multiple folks involved in this. One of the most outrageous answers to a question I've ever asked in my entire life was on electronic health records between the VA and DOD. And the answer to my question was $10 billion in 10 years. There is no question I can ever think of that the answer should be $10 billion in 10 years. And so I think the VA and DOD, I'm glad you've accepted going to one electronic health record. I know implementation has begun in the Pacific Northwest region. I would welcome your feedback on how that is going, and hopefully the answer to the completion of this is not going to be 10 more years and $10 billion.
No, that is a projection. I was very proud to work closely with General Mattis about creating an electronic health record that began the minute an American walked into the military entrance processing station, wherever that American may be, and that there is a handoff. The key for me was interoperability, the ability of the VA to see the entire health record of a veteran. We have had, according to the press, hiccups, but we should have hiccups. My last position at DOD, I was also the head of the Close Combat Task Force. I would never put a weapon in the hand of a young Marine that I had not thoroughly engineered and I had not thoroughly tested on the range. We are testing the system to find out what doesn't work as well as what does work.
So in your understanding, and the Joint Legacy Viewer is not interoperability. It is a patch, and I recognize that. I know Congress, we've done $782 million for the AHR modernization effort in FY18, FY19. We did $1.1 billion. I'm supportive of this program. I think most people here are supportive of this program. However, why is it taking so long to map one record to the other? And have we completed that mapping, the data mapping?
Let me say to you that we recognize your concern, and it's our concern, but recognize the fact that VISTA has 131 instances. What that means is there are 131 data sets that go back decades that must be not only data mapped, but must be combined into a single instance before you can migrate the data over into the Cerner product. And therefore, this is not simply about bringing an electronic medical record to life. This is about moving from a highly disjointed system without data integration to one that is fully data integrated and therefore then interoperable.
Of the 131 instances, do you have a breakdown of what percentage of the total records is in each instance?
Yes.
Okay. Could you share that with the committee?
Be happy to.
And is there one that has a bulk? You know, what is the largest of those 131 instances? Which has the largest number of records in it?
I cannot tell you that, but we'd be happy to have the team come and talk to you about it. And
of the 131, how many of them have been mapped to the new system?
It's my understanding that the vendor has mapped all of them for the transition. Now, there's another piece of this, and that is one of the problems that we saw in the Department of Defense is the problem with user acceptance, especially in their initial go-live. Part of user acceptance is change management, and therefore this is more than simply fielding the electronic record, sir.
Thank you.
Madam Chair, may I ask your indulgence for a moment to
Yes.
finish a response, but it's also in response to something you said at the beginning.
Yes.
You mentioned suicide, mental health. The reason that the electronic health record is so important is something that's not readily seen, and that is the interoperability in an issue like opioid abuse. So an issue like opioid abuse, if some veteran comes to us, and we give that veteran 30 Tylenol 3, and then that veteran will go into the private sector to his local doctor, and that doctor gives him something to sleep. Under this process, that local doctor will punch that information into the record so that now a warning has gone up in VA that we have a veteran who is on the spectrum for abuse, addiction, or something worse, and it allows us to intervene. To your point about mental health, it applies to the same thing with warning indicators from different sources coming into the system. That is the only way, I believe, that we modernize VA again with the, and I will say this is in response to the privatization charge. My view of electronic health is that it keeps VA at the center of a veteran's health, because it's VA that is bringing the information in and supervising everything that goes on in that veteran's life. So I thank you for the indulgence, and thank you for the question, sir.
You're welcome. Thank you. Ms. Pingree?
Thank you, Madam Chair. Thank you, Secretary Wilkie and Dr. Stone, for being with us here today. I'm sorry I was at one of my other committees and missed your earlier testimony, but I appreciate you taking the time with all of us. So the DoD and the VA have focused significant attention and resources on the serious and continuing problem of sexual assault and harassment in the military, MST, which impacts men as well as women. Almost 2 decades ago, the VA created a relaxed evidentiary standard for claims following MST, recognizing that most survivors do not tell and would not therefore have significant or specific evidence in their service records. This was a big leap forward, but it ended up being insufficient. As the regulations were written, the relaxed standard is only available to those diagnosed with PTSD, not to those with other diagnosed mental health disorders. Since that time, medical science has advanced. We better understand the range of mental health disorders that sexual trauma can cause, including major depressive disorders or anxiety disorders, as well as newly recognized trauma disorders as defined by the American Psychological Association in its DSM-5. This means that a veteran who survived rape or sexual assault cannot present secondary evidence to support a claim of service connection if he or she has a diagnosis other than PTSD. So my question for you is, do you believe that VA policy should be updated with a uniform standard so that all veterans who are diagnosed with a mental health disorder due to sexual trauma during their time of service are able to be eligible for claims of disability benefits with the same evidentiary standard?
So I'll let Dr. Stone answer the particulars of the medical conditions, but I will say that all veterans seen for health care are screened for MST, for military sexual trauma. Even those veterans who are not otherwise eligible for VA care because of length of service or what have you, come to VA and will be treated for military sexual trauma and the consequences of that. We have an MST coordinator in every VA healthcare system. It is a reflection of something that the chair has been working on for many years, and that is a recognition of the change in the composition of our veterans population. I'll just give you the statistics. My father was commissioned 2 months before President Kennedy was inaugurated. Less than 1/2% of the force was female. Today, on the active side, it's 17%. It's going up to 20%. In VA, that means it's about 10% now. In some places like Fayetteville, North Carolina, it's 19%. So military sexual trauma, we have reversed many of the problems that existed with the adjudication of those claims, and I'll let Dr. Stone finish the medical explanation.
So we want a wide aperture to attract veterans in. The numbers are frankly staggering. 500,000 women veterans are engaged with us for health care. 29.1% of them, over 125,000, have experienced military sexual trauma. But even after we screen everyone, male or female, for military sexual trauma, not everyone accepts care. Only 80% of women with evidence of military sexual trauma by history accept care with us. We need a wider aperture, and we would support anything that would bring them in at a more effective rate. The second piece is that over 75,000 males screen positive for military sexual trauma, almost 2%. And when you begin to look at that, and as the parent of a daughter as well as the husband of a veteran, these are deeply troubling numbers. So VHA would support anything to update our regulations that would recognize the emerging nature of this problem and to bring them in. But recognize that today, that even if you're not registered for health care, you are welcome to come to VHA for care or come to one of our vet centers and we'll bring you in. We recognize that trust in this system, although very high with our engaged population, we need to do everything we can to reach out and bring that additional population in.
Well, thank you for recognizing the significance and scope of the problem and also acknowledging that it is both a male and female issue and goes back quite a long time. And I'll just look forward to working with you. I'm about out of time, but I'm also not just talking about coming to the VA for care, but qualification for disability benefits, and that is in particular what I'm concerned about. So can I just confirm that you're willing to work with me on those very specifics that we can't work out today?
Yes, Congresswoman.
Thank you very much. Thank you, Madam Chair.
You're welcome. Thank you, Ms. Pingree. We'll begin our second round of questioning. Mr. Secretary, I want to turn back to the issue of VA veteran suicide prevention. As you mentioned, as I mentioned, it is I don't think we really have a higher priority in this subcommittee. It's something I've been asking about and focusing on since I became the ranking member. And I know the VA says that it's the highest clinical priority, but actions speak louder than words. And we have a November 2018 GAO report that found that VHA's suicide prevention media outreach activities declined in the last few years. That included public outreach to raise awareness of the Veterans Crisis Line. The Veterans Crisis Line itself has had its own set of problems, which were the subject of an IG report, or an IG investigation. Social media content declined 86% between 2016 and 2018. The VHA only spent $57,000 out of their $6.2 million paid media budget last fiscal year on veterans suicide outreach. How many veterans could we have potentially reached if the proper funding for outreach was used? When we're talking about the veterans population who are at risk of suicide, veterans are very proud individuals. They are not folks who we are able to reach through normal channels and notice as they cross the threshold of a VA hospital or clinic. That's an completely unacceptable situation, and I want to know what happened with the spending of this funding over the last couple of years and how you're fixing it.
Let me start with that GAO report, and I will say that it's maybe self-serving that GAO report stopped, that the reporting date stopped before I became secretary. And of that $15 million, I believe I authorized $12 million to be spent in the last 2 months of the fiscal year, because I agree with your assessment, and I think I mentioned that to you in one of our two visits.
You did.
Suicide prevention is the tragedy that suicide is the tragedy that you mentioned. So 14 out of the 20 veterans who commit suicide are outside of VA. That also includes probably 2 to 3 every day from active duty and a number from the Guard and Reserve. We are spending $206 million for suicide prevention in FY 2019. We have had 20,000 outreach events in this fiscal year alone. I will also say that one of the tragedies that we have, and I mentioned it to Mr. Case.
I'm sorry, I want to be mindful of my own time, and I want to ask you to focus on what are you doing to change the numbers. I understand what you have been doing.
Right.
The numbers have not substantially changed.
So
if we are guilty of doing the same thing over and over and expecting the same result, then that's the definition of insanity.
So the crisis line, 2,000 calls a day. We are expanding our footprint in terms of social media outreach. You were correct. The department didn't do that under prior leadership. That's a bipartisan criticism. We have national suicide coordinators implementing a national strategy for the first time, and I'll let Dr. Stone finish in terms of the clinical response.
I think there's 2 ways to approach this. Number one, to find risk subpopulations of what makes up the 20 a day. Number 2, to do a public health outreach. And part of the outreach in the media portion that you've referenced, Madam Chair, is about reaching out to the whole veteran population. But taking...
Not as opposed to just those who you're interacting with already.
Exactly.
I had mentioned earlier to Mr. Case that in his state, half of the veterans are not in our system. And I have gone, in fact, to native populations, native nations, and asked them to double their efforts to get that outreach. One of the sad things is that we know that the majority of those who take their lives are from my father's generation, the Vietnam era. Some of these issues began when Lyndon Johnson was president, and I would be lying to you if I said you would be able to eliminate all of them. I will say, though, that the tragedy of the 19 who have taken their lives on VA property in the last 2 years, we've also had almost 250 interventions on those campuses in stopping that. There's no connection that we found clinically between the taking of a life in Bay Pines and the taking of a life in Atlanta. Again, I would be gilding
Except that those are veterans that are getting treatment, that are in the system.
And that's why the outreach is important, particularly to non-traditional.
I want to let Dr. Stone just finish.
Yeah, not all are getting treatment. So one of our most recent suicide over last weekend occurred in a veteran who came to us because he knew, and he had left a note, that his family would be taken care of and informed of his death. He was not in care with us. So you can't lump all of these together and say it's some sort of message. What we do know is that there are portions of this population that we can identify. For instance, 3 a day come from veterans who have tried to commit suicide previously and were in our emergency rooms. And when they're in our emergency rooms, they survive their suicide attempt. But then they go out and commit suicide. So we released earlier this year a study with Columbia about what we call a suicide safety contract that we have now expanded across our entire delivery system. And we are now beginning to get anecdotal evidence of saves across our entire system, and we can review those. And I know I've gone over the time. But the other problem we're having is 3 a day that we count as veteran suicides are never activated Guard and Reserve. And those never activated Guard and Reserve are not eligible to come to us for care. And we're working with the Guard and Reserve Act leadership at this time to try and figure out how to bring them in. That could be really some support from you in the future.
Well, if you need our help, please let us know.
And I would also add, when you mentioned leadership at the beginning in your statement, we now have the Pentagon's top expert on our staff, Dr. Keita Franklin. That is new. She is permanent now, and that is a sea change, and we are increasing the size of her office to reflect the concerns that you've laid out.
Thank you, and I apologize for going over my time, and I really want to make sure that we can laser focus on this, both in terms of our resources and making sure that we have the right structure in place to make sure that it's not foolproof. We're not going to catch every veteran. A very determined person is going to commit suicide if that's what they are determined to do. But anyone we can reach, we have to do everything we can to have our system make it more likely that we can. Mr. Carter, Judge Carter.
Thank you, Madam Chairman. Wow. First, what Mr. Hurd was talking about, I came on this committee in 2004. We talked about it in 2004. That's 15 years. We've been talking about interoperability between the Defense Department, and the $10 billion may be short, but we've thrown money at it. I just can't. It drives me nuts. Secondly, everybody knows, both the Army. I mean, I've worked with suicide prevention in the military and outside the military, and in the VA, and this is a horrible thing. What bothers me, the VA shouldn't have the reputation of this going on forever, and neither should the military. And I don't know what the solution is, but I know some 3-star and 4-star generals that have been pulling their hair out on the issue of suicide. So these seem to be never-ending conversations, and that really hurts. Now, Enough tirade. And by the way, whatever's happening in Alabama, fix it. Okay? Now, in Temple, I don't have a whole lot of problems. We'll tell you this, though. Whenever I go talk to veterans, and I do this all the time, I get together with these vets all the time. They say, good news, medical care is great. Bad news is the people between us and the medical care that are driving us crazy. And we think we work pretty good. That sounds like part of what our problem is. I want to raise a couple of quick issues that are relative to my district. I asked you to come visit. We're proud of our hospital. We're proud of our people. We think they do a good job. We've had to change that. 10 years ago, I couldn't say that. Today, I can say the health care is really good and people are happy with it. They're getting happy with the other part. But we're 50 years old. We're 7th in the nation for overall military retirees and veterans in the whole country. And that's why I asked the first question about your review of the system. And as you look at it, I'm not asking for you to rebuild the whole thing, but I want you to take a look, if you can, especially at ambulatory care. We've really got an issue there. And that's really all I'm going to say about this. But finally, this came up. Veterans, for a long time, have needed audiology, hearing aids. I got some. The demand is high. The backlog is huge. And in 2016, we authorized to hire hearing specialists following consultations on the qualifications they needed to have to service. Have the qualifications been established? Does the VA plan to address the variability among state licensing requirements? Again, the VA set a national qualification standard. Because when you get the age of our Vietnam and Korean War and whoever survived in World War II, this is something you really need.
So hearing aids are one of the largest prosthesis that we buy, probably second only to CPAP machines. As a combat veteran who has combat-related hearing loss myself, I am incredibly appreciative of the VA's expertise in getting me audiology equipment in my ears today that I can actually hear you. And so we do very, very well in a national contract in how we buy hearing aids. Our ability to get veterans in, the bureaucracy that people have to go through needs substantial work to resolve. But once the veteran is in, the care is as good as any place in the world.
And I agree with that. I do agree with that. I don't hear that complaint. It's getting in the complaint I hear.
And that bureaucracy is the primary focus that we've focused on in many of your colleagues' questions this morning of how do we improve that, and therefore is the number one effort of the Secretary to improve customer service and reduce that bureaucracy.
I think I'm close to retiring. So
Thank you. Sorry, Mr. Case.
I think, first of all, with respect to your stat on Hawaii, that 50% are not in the VA system, I don't want to have the impression left that that's because of any innate failing on the part of the VA or as a result of outreach. Actually, probably a lot of that is accountable to a very good state law that we have,
Absolutely.
Which provides a very high level of coverage as long as those veterans are employed. This law was a pretty revolutionary one. It's been around for decades now.
And I didn't want to leave that impression.
Okay. Well, I think I just wanted, when you said that, it jarred me a little bit. So I don't want to say that. However, outreach is still the issue because there are too many that are not covered under that law, or for that matter, any other state. I think what I wanted to follow up on a comment on VSOs from this perspective, because I'm going back to my Veterans Fair in Honolulu example and walking around talking to the VSOs, incredibly committed, in many different ways. Do you feel that we are adequately incentivizing or encouraging or welcoming VSOs into the continuum of outreach and care? Or are there ways that we can do a better job there? And what I don't want to say in the context of this question is that they should in any way, shape, or form replace the obligation. But they're clearly there. They want to help. They're motivated to help. And are we, I just asked the open question, have you considered whether there are other ways that we can, additively include them in the care, especially in the areas that we've talked about today, whether it be outreach, because as you well know, veterans are the best people to outreach to veterans, and transportation, where they certainly do much of the care right now, and I'm sure you know of other ways. So can you comment on VSOs a little bit and whether we can, whether you've given thought in that direction?
I think Dr. Stone will agree. We could not do what we do without them. If you go to the medical center on Honolulu, you go to the clinic on the Big Island, there are offices that the VSOs maintain. They are really the living link to the veterans population. They provide much of the legal and intellectual support for our veterans who are looking for answers on benefits. So they are an integral part of our community. What has changed, though, is the nature of the veterans population, and you see that in Hawaii as well. For the first time since the fall of Saigon, more than half of our veterans population is now under the age of 65. And that is where we have to go beyond traditional means, because they're not joiners. They don't follow the pattern that the Vietnam era, the Korean era, and the World War II era have. So many of the non-traditional avenues that are out there, we are trying to enhance. I won't name them because in naming them I'll exclude some, but I'm actually trying to expand the aperture on the number of institutions we can bring into VA to reach out to veterans.
Private institutions. Private institutions, or back to my question,
Yeah.
VSOs specifically,
Yeah.
are there policy judgments, legislation?
No, I don't think so.
Areas that we can do to
as long as they meet our standards. So now we're looking at groups like, well, I'll just name a few, that weren't there 10 or 15 years ago. Wounded Warriors, Elizabeth Dole Foundation, Independence Fund, people who address specific needs in the veterans community that in some cases are new. So expanding that group is absolutely on target, and I'll get you a report on how we're doing that.
Thank you.
Yes, sir.
Yield back.
Mr. Rutherford?
Thank you, Madam Chair. Mr. Secretary, I'd like to follow up on a question I asked in the first round on the Section 304. It's my understanding if you don't fund Section 304 provision very soon, that the VA will miss the deadline for the class entering 2020. Is there any assurance that you can give us that the funding will be made available for that class, or when it will be available? You just said it was slow and never really gave us a timeline.
Oh, the GI Bill. Yes, let me address GI Bill. I made a command decision back in August. We weren't doing right by our veterans. The IT system that we had was not able to adopt to the changes that the Congress wanted. And I said we will get money out to our veterans, even though it was based on the previous year's funding levels. I expect that by December of this year, we will have fully satisfied the dictates of Section 304, and we will have made our veterans whole. And that includes making sure that those veterans who have been overpaid do not have to pay us back.
Yeah, I may have confused you with the question. I'm actually talking about the Veterans Healing Veterans piece on getting the physicians I'm sorry.
So we have certainly struggled with the fact that the complexity of the Mission Act was an unfunded mandate. And therefore, portions of this have been a struggle. We do believe we're going to have the scholarship dollars to bring forward, and we'll be able to repurpose some money to do that. And so I'm optimistic that the scholarship dollars will come through.
By the time for the 2020 class?
Yes.
Okay.
I apologize for misunderstanding.
No, that was my fault. If I could ask a question, since World War II, veterans have had the right to choose their prosthetic and orthotic care, whether in VA facilities or in community-based clinics that may be more convenient. There was a proposal in 2017, as you know, and again in 2018, to make the VA, rather than the veteran, the final arbiter of where veterans can receive that care. Can you talk a little bit about what the intent is on that issue?
I don't think that proposal has gone anyplace, and we remain convinced that this is a very complex discussion between the veteran as well as our providers, and the tiebreaker should always go to the veteran. If the veteran is comfortable with a prosthetist out in the community, that's where it should stay. Now,
Okay.
we do
So there's no concerted effort to move that back inside VA only?
There is not.
Okay.
But going back to the hearing aid discussion that we had earlier, or the CPAP, we are moving CPAP into a nationwide contract. And in the effort to do that, that is to be good fiduciaries of what you provide us in funds. We do not feel the same way about the prosthetic work. Now, in the prosthetic work, it is just so complex and such an intimate relationship between the prosthetist and the veteran that we've got to allow that to continue.
Okay, and my time is almost up, but I'd like to ask one more question. Well, first, let me congratulate you and the President on the executive order dealing with the official time. Horrific situation that was existing where nobody was even tracking official time. You know, GAO couldn't even determine how many hours were being used. A horrible situation. A doctor who spent 100% of his time on official time saw no patients that year. Can you tell me where we're at in that cleaning that program up?
We've implemented that. You mentioned the situation that we found ourselves in. About 430, 450 professionals, medical professionals, did not see a patient, did not read a record. And the tragedy there is that with us competing for medical talent across the country, that is something that is a disservice to the veterans that we serve.
Well, thank you, and congratulations on the great work on that, by the way. And my time is up. I yield back.
Thank you, Mr. Rutherford. Mr. Bishop.
Thank you very much. Mr. Secretary, it's my understanding that the Department of Veterans Affairs has close to 46,000 job vacancies. And of these vacancies, close to 41,000 of them on the healthcare administration area. What is the department doing to fill these vacancies, and how much is pay parity affecting the filling of those jobs? And in connection with that, as one of the 4 statutory missions, the Department of Veterans Affairs is required to conduct education and training programs for students in healthcare professions to enhance the quality of care provided to veteran patients within the Veterans Health Administration. As you know, one of my major concerns over the years has been the VA's relationship with historically black colleges and university medical schools. Can you elaborate on the VA's partnerships with historically black colleges and universities, and what can the VA do to increase targeted training and education programs for the HBCUs and the minority-serving institutions, and what are the plans to expand the relationship with these institutions? If you can sort of integrate those two questions, the vacancies and the relationships with the HBCU medical and health professions universities?
First, it goes back to something that the chair said about leadership. When I came to VA on the second or third day, I had 2 briefings from 2 senior people, each giving me a different number as to the number of employees that we had. And I asked what I would ask in a military environment, where's your manning document? And you know, because of your service, manning document is requirements, and the people who meet them, we didn't have a manning document. So I managed to bring over the senior personnel officials from the Air Force Department, and they are working on that. In terms of our vacancies, we hired 45,000 new employees last year. Each year we gain more staff than we lose. We have a 9% vacancy rate, which in the American healthcare system is a lot lower than the average, which is about 19 and 20%. I would be lying to you if I said I'm going to look to fill all those vacancies. What I need to focus on, and what Dr. Stone is focusing on, is where we have the greatest need. Primary care, women's health, mental health, those are and nursing. Those are the areas. We are improving those outcomes, and in terms of the outreach to historically black colleges and that medical training, it is absolutely vital. And I mentioned this in some part when I met you last year at your conference. I'm very cognizant of underserved populations. And the contributions those underserved populations have made to national defense. When I visit Atlanta again, I hope to visit the historically black colleges in the Atlanta area to talk about those. And I'll let Dr. Stone fully answer the issues that go with making sure that we bring more of those doctors and nurses into our system.
If, in fact, our vacancies were affecting wait times, we'd be very concerned. But our wait times are actually reducing across our entire delivery system. And therefore, as we approach the fact that both of us come from DOD, where we're used to having manning documents, and we have not had one here and continue to build out a manning document, I would ask you to consider that.
Yeah, let me just, I beg to differ with and maybe statistically you are reducing the wait times, but I have a staff member who was diagnosed with cancer. I'm sorry, who had a fall. She's a veteran, and it took her like 2 months to finally get to an orthopedic to get scheduled for the reconstructive surgery that she needed on her knee. That was unacceptable. And she's a staff member. So, I mean, I don't know if the wait times are shorter or not, but
So there's a nationwide problem with the lack of orthopedic surgeons across the entire American delivery system. But that said, that doesn't mean we shouldn't be working to recruit every orthopedic provider we can. So let me come to the next
outside
piece.
the VA, the choice program.
And I think that's the key to the Mission Act.
Getting the permission to do that was what caused the delay.
The chart that the chair has, if a veteran does not have access in a timely manner to those specialty services, we will give that veteran the opportunity to go into the private sector because the veteran's health is the key.
So with the chair's indulgence, we have 1,700 academic affiliations. 5 of them are with historically black colleges and universities. Those are essential partnerships that we'll continue to focus on in the Mission Act as we attempt to obtain great physicians and nurses to serve.
Let me just say this with regard to my staff member. She was out of work from September until February as a result of the slowness and the delay in being able to get her surgery, being able to do a rehabilitation and being able to come back to work. That is entirely too long for just a reconstructive surgery for the knee.
May I ask what VA medical center she was in?
Central Alabama.
Central Alabama, okay. Okay.
Mr. Hurd?
Thank you, Madam Chair. I want to echo something that Judge Carter said. Again, veterans, they love their care when they actually get it. The frustration is, you know, everything between them and getting their care. And Mr. Secretary, if you do come down to Central Texas, let's get you down to South and West Texas as well. We'd love to host you and show you some organizations like Pink Berets, which is an entity that is helping on MST. And we're working with them to make sure they're part of the VA family, similar to like an organization like Endeavors. These are folks that are doing some really incredible work. And I want to get back to some of the technology piece. I am glad that you know there's 131 incidents of VISTA, because 2 years ago we didn't know that number. That is a sign that we're moving forward. So this is probably the first time I've ever been encouraged about the movement, and I will say what y'all are doing in trying to achieve a longitudinal healthcare record is really transformational, not only for our veterans population, but for all American citizens, because I do believe this becomes a national standard for others to apply. So that's why we spend so much time. I think this committee is always going to be supportive of that effort. FTARA scorecard. Mr. Secretary, do you know what your score is on the FTARA scorecard? It's a B+. That's pretty good. Yeah, and that's why I ask it that way. It's a B+ because you have given a lot of authority to your CIO. Your CIO is reporting either directly to you or the deputy agency head. You are doing things like, you know, your software licensing within your network. That's going to help you save a lot of money. However, the one area is the MGT Working Capital Fund. That's Modernizing Government Technology. This is a fund that's supposed to be available to help you when you make good decisions to modernize your infrastructure. That money you save from, you know, getting rid of some of the software licensing that you're not using can be put back into modernizing your system. Your FTARA scorecard indicates that you are creating a culture of modernization, and I would welcome at a future hearing your report on why you do not have an MGT fund, because I think that is a tool that can not only help with this EHR effort, but modernizing your systems like scheduling to make sure that's not as cumbersome of a process. If y'all have a comment on MGT, I'd welcome it. Otherwise, you can submit it in writing.
Yes, but I'll address that in response to a comment that the chair made at the beginning when it comes to vacancies in leadership. We do now have an assistant secretary for CIO. For our IT systems. One of the Pentagon's leading experts, confirmed now, and in terms of the program head for EHRM, Captain John Wyndham, who worked on and developed some of the Navy's most complex IT systems. So we are moving on the leadership, and my view of leadership is to give those with the talent the leeway to go. I apologize, I didn't know the acronym, but it is reflective of a command philosophy that I learned in the military.
And you're an example for other entities. And one area, I'm former CIA, spent almost a decade as an undercover officer. Many of my colleagues are what we call ground branch or air branch in special activities. These are men and women almost exclusively out of the military. I believe it's like 99% come from the military. They put on a different kind of uniform that most people don't recognize, right? But oftentimes they are injured in service to their country. Now it's under the operational control of the CIA and not Department of Defense. And oftentimes they do not benefit from some of the care that they could get at the VA. I would love to work with you on this. I know some of my colleagues in the Senate. I don't know if this is an issue that you're aware of. If you are, I'd welcome your feedback. However, this is something that, again, it's a small subset of individuals, but these are men and women that are going truly into harm's way on their own. and this is an important issue to try to address.
So in combat operations, I was intimately familiar with the sacrifice that these members make for our country. That said, one of the most deeply troubling pieces of that was the inability for us to move them through the system in an effective manner. There's lots of complexity to that. We would look forward to working with you on it.
And I'll talk to Director Haspel.
Excellent. I appreciate that. And Madam Chair, thank you for the indulgence, and I yield back.
My pleasure. Thank you, Mr. Hurd, and thank you for your service. Ms. Pingree?
Thank you, Madam Chair. I'm concerned that the VA is departing from some of the congressional intent through an overzealous interpretation of the VA Accountability Act by relying too heavily on quantitative rather than qualitative metrics when assessing personnel performance. Our offices hear every day from veterans who are stressed out from the experience with the VA claims process, which obviously you've been addressing quite a bit today. And while there's a need to address the frustration with backlogs and delays, VBA's adjudication changes have now left veterans feeling that the goal is simply completing claims without attention to quality processing, denying when possible and making it difficult to appeal. I hear from employees who say the VAA is being implemented for regional offices to hit their metrics, quote unquote, with a focus on speed rather than accuracy, more volume and less personalization, more work with less support. If turnover is high and employee pride and job satisfaction are suffering, that negatively impacts veterans. I know of 6 cases of VBA employees dismissed at the Togus VA hospital, which represents my area. Some dismissed employees are veterans themselves, some had decades of service and were within months of retirement, and they represented employees with years of positive quality metrics. Your testimony states that there is an 11% vacancy rate at VA. A VA report says 3,106 employees were removed in CY 2018 under the VAA. How many of those employees were replaced? How long does it take to train a veterans claim rater? How do you compensate for the loss of experience when a longtime employee is replaced by a first-timer? I'll also just add that I understand the drive to make the system more efficient, but do you think it's an efficient use of resources for the department to be so aggressively focused on numbers rather than quality and showing experienced people the door rather than use positive incentives to improve productivity?
Let me address what led to the changes that this Congress mandated. We had backlog of claims and appeals numbering over 600,000. That was untenable. As part of our drive for modernization, both on the claims level and on the HR level, we are changing the system so that veterans do not have to wait in many instances for someone to actually touch a record. There's enough experience in the Pentagon and in the private sector where automation will help, particularly in the triaging of those claims. The second part of your question is, what are we doing on the other end of that, in appeals modernization? You are correct that a quick solution is not always the best solution, which is why there are now 3 lanes of claims. There's the higher level review lane, there's the standard review lane, and there's a supplemental claim lane that will address the concerns that veterans have if they believe that they have not been given a full hearing. We have also expanded the number of employees who are in that VBA system. I will get you more numbers to answer the specifics of your question as to how many we have replaced. I don't know that off of the top of my head. But modernization on the HR side is absolutely vital, and we have to get our veterans through the system, and part of that is modernizing the system, which you know a great deal about. Yes.
Let me add to that, if I may. There is never an excuse for malicious behavior, reckless negligence, or criminal behavior. but we have 341,000 humans giving care inside the VHA. To err is human. And therefore, we must create a just culture that recognizes the fact that errors can occur and focus on the why, not the who, in order to prevent veteran harm and prevent harm across our medical care system. So if that was the focus of your question, I think that we are rolling out a just culture effort across the entirety of the VHA. And we had the opening 18 hospitals participate in the beginning of that last week.
So thank you for your answer, and I will appreciate seeing sort of more numbers and background. And just to reiterate, I understand, and I think that's a common concern, and particularly in people who have served on this committee much longer, about the wait times and the frustration with that and decisions being made. But I guess I'm just adding some anecdotal information that says that if there's too much of a focus on numbers and we lose good employees, it could cause problems. Thank you, Madam Chair.
Thank you, Ms. Pingree, and thank you for staying on top of these really important issues. And last but not least, Mr. Cartwright.
Thank you, Madam Chair, and thank you, Secretary Wilkie, for being here, and you too, Dr. Stone. I want to talk about nurses for a moment. Exceptional nurses are just as economically valuable to a medical center as they are to the body, mind, and spirit of a sick or injured veteran. Does the VA have a plan for retaining high-quality nurses in areas where private sector nurse pay is higher and there is an unmet demand for nurses in the private sector?
As you know, nurses in America change jobs a lot. In fact, on any given year, 17.8% of America's nurses change jobs. Within the VA, our turnover rate of our nurses is at 7.8%. Now, it's not because we're paying them a lot. It's because they're connected to the mission and they love the kind of care that a lifetime commitment to America's veterans delivers. And if you wander through our system, almost universally, what our nurses say keeps them with us is the ability to know their patients and see them over and over again across their lifetime and of all the challenges of their lifetime. That said, we do have problems with capping out of pay rates, especially in certain areas. And you've given us some latitude in locality-specific pay where we can add some pay, but we still cap out. And that is an area that you will see some legislative effort in as we present to you options of how we might approach retaining nurses as pay goes up. The other thing is maximizing the use of licensure to the maximum extent. We need nurse practitioners that can work to the peak of their license across the nation. And there are areas of the nation that we struggle with that, even with our federal supremacy.
Thank you, Doctor. Next question is, a year ago, Congress reacted to the problem of scam artists targeting veterans and charging illegal fees for helping them apply for benefits like the aid and attendance benefit by passing the Veterans Care Financial Protection Act, which President Trump signed into law on March 9th, 2018. Can you give me a report on the department's implementation of this law? And I don't mean to make it a pop quiz. If you want to respond separately, that's fine.
No, sir. I can respond to that. You've hit on a problem that we had to address, and I'm sad that it took an action of Congress for us to address that, but we give a warning to our veterans across the board that there are individuals out there who are attempting to steal their benefits, their pensions. We provide anyone who assesses our system not only a verbal warning, but a link to the Department of Justice. We tell them when we meet with them that there is that option available, and we also refer any issues that the veterans bring to us, to our general counsel and our inspector general, and those are also handled in conjunction with the Department of Justice. But it is absolutely vital that we continue that outreach to make sure that they are aware of the unscrupulous practices that exist out there.
Thank you, Mr. Secretary. Finally, talking about the VA's Choice Program, I was concerned, AFGE requested a formal meeting with you, Secretary Wilkie, after you began your tenure. They have a statement out there that you have not responded to the union's request. At this point, have you, in fact, met with the duly elected representatives of AFGE, which is roughly 70% of your workforce? Have you met with them?
I have not.
Will you?
I will meet with them after negotiations are done. I can't, I will not step into the middle of that.
Well, now, the union's national president, J. David Cox, contacted you on September 12, 2018, asking for a meeting to discuss important issues to your workforce. I do have a copy of his letter, and I do ask unanimous consent to make that letter part of the record, Madam Chair.
Without objection.
Okay. Will you answer his letter, Mr. Secretary?
I believe I did back last year. I don't have a copy of it in front of me, but I think I did.
Thank you.
And I'll provide, if I, whether I did or didn't, I will provide you that copy if I did. But I think I did.
And if you didn't, you're going to write him a letter.
And I will do that, yes, sir.
Thank you, Mrs. Secretary.
Yes, sir.
Yield back.
With that good news, we've reached the conclusion of our hearing. Without objection, please show the flow chart for community care eligibility of the VA Mission Act pending revisions entered into the record. And just to remind members that tomorrow we have a hearing that will focus on the border wall and its impact on military readiness. And that hearing will be in this room at 2 p.m. And the committee stands adjourned until tomorrow at 2 p.m.